Welcome. And before we begin today's proceedings, I'd like to begin by acknowledging the traditional owners and custodians of the land on which we meet today, the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past and present and the elders from other communities who may be here today. Today we're going to hear from Peter Gibbs. Peter trained as a medical oncologist here in Melbourne, did his MD at the Ludwig Institute, and then after 2 years in Denver, Colorado, came back and has been a medical oncologist at the Royal Melbourne and Western Hospitals since then. Peter is one of the people who came to us from the Ludwig, and as you'll hear today, when he talks about some of the things that he's doing in colorectal cancer and now moving into pancreatic cancer, their lack of vision has been very much our gain. So, Peter Gibbs.
Thanks, Liam. So I'm giving a talk today about cancer biomarkers, which is something I've been interested in for a long time and I think really hasn't been done very well by the oncology research community. I'm going to talk a little bit to start with about some of the challenges in managing colorectal cancer from a clinical perspective, some of the challenges we face day to day in treating our patients and trying to optimise their outcomes, and focusing particularly on how I think we can make better progress than what we're doing at the moment. So as we all know, there's lots and lots of money being invested in developing new drugs, and we do see some gains, but unfortunately it's a very expensive way of improving outcomes. And often we're treating patients that receive little or no benefit. So patients might receive tens of thousands of dollars worth of treatment and still not receive any gain in terms of their cancer, but still experience the toxicity, the adverse effects of that treatment. So I'm focusing on biomarkers, which I think has been largely neglected by the oncology community. And the key here is what we're trying to do is better use the resources that we do have, the drugs that we have, how do we better use those to achieve better outcomes and hopefully do that in a very cost-effective way. So the two examples, two areas I'm covering today are early stage colorectal cancer and also talking about metastatic colorectal cancer. The early stage biomarkers of immune response and of ctDNA, and in later stage EGFR ligands and circulating tumour DNA as well. A large part of our effort is in collecting tumour and data, and we do have a very collaborative approach to research. So we're working with the groups that do have the biomarkers of interest that give us access to novel agents and allow us to ask important questions, and also working with the experts. So for example, with the circulating tumour DNA, it's a bit of a no-brainer to work with Bert Vogelstein, who developed the technology and continues to lead the world in that area. So as background, colorectal cancer is our second most common cancer. This is Victorian data, and the second most common cause of death. I won't be talking much today about pancreatic cancer, but that is an increasingly important cancer. A few years before this, it was number 7. It's now number 5 in terms of mortality, and it's projected by 2020 to be the second most common cause of cancer death. Unfortunately, it gets very little focus in terms of research, and to date, there's been very little progress. So just walking you through what happens in the clinic on a day-to-day basis, we have a patient that presents with bowel symptoms. They have a colonoscopy, such as on the left, finding a colorectal cancer. We do a CT scan that doesn't show evidence of metastatic disease, and then the patient proceeds to have their bowel tumour resected. That section of the bowel is taken out, and along with the fatty tissue around that bowel is sent off for pathology examination. And then the pathologist tells us whether it's a stage 1, stage 2 or stage 3. And this dates back to 1932 with Cuthbert Jukes at St Mark's Hospital describing Jukes A, B and C, which we now tend to call 1, 2 and 3. We've found a few other clinical and pathological features that are important in terms of outcome, but we're still dominated by this stage 1, 2 and 3 approach to outcome. And based on that, we decide whether to give patients 6 months of chemotherapy. There's a particular dilemma, though, when we come up with stage 2 colon cancer. And to try and explain that dilemma, the problem is that 80% of these people are cured. That's a good thing, but the problem is 20% do recur. And that's despite having good surgery and their scans not showing any evidence of residual disease, any evidence of micrometastatic disease. So the goal in improving outcomes for stage 2 colon cancer would be to use adjuvant therapy, adjuvant chemotherapy, to try and eradicate this micrometastatic disease, stop it becoming established metastatic disease, and curing those patients. The particular challenge is we can't define the 20% of patients among all of those with stage 2 colon cancer that are at risk of recurrence. And when we do treat everybody, there's a small treatment benefit. So just to show you that in a different way, if we had 100 patients with stage 2 colon cancer, looking on the left there, they're pretty much a homogeneous group. There may be some shown in the darker green here that have higher risk characteristics that might increase their risk of recurrence 1.2, 1.5-fold, but we really can't define any particularly high-risk patients. But if we don't treat them, after about 5 years, about 20% or so, 20 patients have recurred. And that recurrence does come from the low-risk patients, so some that have low-risk features do recur, some of the ones that have got high-risk features don't recur. It's very hard to predict outcome. If we treat all of those patients, every patient, all those 100 patients gets chemotherapy, we end up curing 3 patients. So that means 97 patients that we treat with chemotherapy don't benefit. So some patients, the cancer still comes back, those shown in red, and for most of them, the cancer was never going to come back, and so the treatment was wasted. Now, some people think treating 100 patients to benefit 3 is helpful, and some clinicians do that, but obviously it's a very low yield on the investment in terms of time, effort, and dollars. So how have oncologists been approaching this, trying to improve things? So what we've been doing a lot in recent years is trying to develop new drugs, and this is an example of adding oxaliplatin to our standard 5-FU chemotherapy, very large clinical trial, about 2,000 patients, and the stage 2 data shown here. So patients getting chemotherapy, the blue line, slightly above the yellow line, but it doesn't actually reach statistical significance. So there's no evidence that adding oxaliplatin really improves things by any significant amount. The other thing that's been focusing attention is various gene expression-based recurrence scores, and there's now 4 or 5 of these at least out there and being sold, and people are pushing for these to be done. But this is an example of one, and just to point out the very modest hazard ratios associated with these recurrence scores. So this one's got a hazard ratio of 1.38. So you can define groups in terms of high, intermediate and low risk, but it doesn't really separate them very much at all. So what I'm interested in particularly is biomarkers, and just to remind you, there's different types of biomarkers. So prognostic biomarkers, these are biomarkers that indicate a patient is at high risk of an event. So someone that's had cancer but is at high risk of recurrence. A predictive biomarker is telling us which patients will benefit from treatment. Is this patient going to be benefiting from the chemotherapy or not? So if you look at the landscape for colorectal cancer, it's a pretty sobering situation in terms of biomarkers that I and my clinical colleagues use in our routine day-to-day management. For patients with stage 2, if they've got deficient mismatch repair, about 20%, we know those patients have a good prognosis and we don't usually offer adjuvant chemotherapy. In advanced disease, we look at RAS mutations within the tumour, and that predicts resistance to epidermal growth factor receptor inhibitors. But that's the total list in terms of biomarkers that we use for colorectal cancer. And if you look at pancreatic cancer, it's an even shorter list, unfortunately. So everyone gets the same treatment, which is not a very productive way of treating patients, particularly as treatments become more expensive. So if we take a step back, and what are the potential biomarkers that we could be using for colorectal cancer? And this is a list that I put together, and actually this was pulled from an oncology textbook in 1995. So about 20-odd years ago, we had a long list of potential biomarkers, and none of these have effectively made it through to clinical utility. And there's a whole lot of reasons why that's occurred, but largely because we haven't developed biomarkers or thought about them, I think, carefully enough. It's a story across many tumour types, so this is looking at all cancer biomarkers, and the graph clearly shows that the publication rate continues to increase. We're seeing lots and lots more reports about biomarkers, but as shown in the red, those that are reaching patent and clinical utility is still very, very small. And there's lots of reasons for that, and I don't really want to go into that because it's probably a separate talk in itself. There's potentially fraud, false discovery, and true discovery. And often biomarkers do appear to have some impact, but the hazard ratio is very modest. It's not big enough to make us change our practice. So what we've been doing for the last 15 years really is trying to develop a better way to approach biomarkers in colorectal cancer, try and unblock this move from biomarker discovery through to clinically useful biomarkers, which is how we assess success. It's not demonstrating a biomarker, it's not getting a publication, it's something that we would use in the clinic that's going to help us to treat our patients. So we've taken a unique approach where we've established a network of hospitals. We collect comprehensive data on the cancer patients that we treat, and most of those have formalin fixed tissue for which we can use for our research purposes. We're then looking at potential biomarkers that may have potential clinical utility, And the key here, I think, is trying to define those that might have a major impact, at least a hazard ratio of 2. So not looking at things that may or may not make a little bit of a difference. As I mentioned before, it's very much a collaborative approach. And what we're trying to do initially is to understand our biomarkers using the tissue and data that we do have, trying to understand the clinical, pathological associations, interactions, and a potential impact on outcomes. Ultimately, what we'd like to do is prospective randomised controlled trials, which I'll mention at the end. So what we've been doing routinely is collecting clinical data on the patients that we treat. We collect the pathology data, we collect the treatment data, and we collect the outcome data, looking at cancer recurrence and death as the two major endpoints. We're also trying to treat our patients according to standard protocols, so everyone gets the same workup and the same treatment, which makes it easier then to look at the impact of a biomarker. So there's a long history, I think, of biomarkers and people trying to do them within the context of clinical trial cohorts. And that's been the dogma in medical oncology, that you do a clinical trial and you add your biomarkers into the clinical trial. You don't think about the biomarkers first, they always come second. Unfortunately, that approach hasn't been very successful in terms of translating into useful clinical biomarkers. So just to summarise, we started in 2000. We've now got over 7,000 cases of colorectal cancer that have been collected across 6 hospitals. We're approaching 100 publications from that, both data and tissue-related publications. And for example, we've got 1,400 patients, well-characterised patients with stage 2 colon cancer that we've been following up as part of their routine clinical care. So one of the biomarkers back in 1995 that was suggested is inflammatory infiltrate. And like all of the other things on that list, it's still of interest potentially, but it hasn't yet impacted on what we do in our day-to-day patient management. So just some of the data. This is a science publication from 2006. So this is a group led by Jerome Gallon, and they looked at a series of about 400 patients with colorectal cancer. So there's a mixed patient population, stage 1, 2, 3 and 4 patients, and they didn't have very good follow-up or outcome data on these patients. But they clearly showed that you can divide patients up into high risk and low risk based on their immune score. So they looked at the CD3 expression within the tumour, the invasive margin and the core, and also looked at CD45 and came up with a scoring system. And what they're able to show very clearly on the right here is that you can divide patients into low risk and very, very high risk. So this looks like a very interesting clinical biomarker. There's a huge difference between the two groups. This is something I think that's worth pursuing, worth validating, and could be something we could use in the clinic. So typical, I suppose, of medical oncologists or research in general, what we tend to do is we see something in a small series, then we think, let's go big and also demonstrate in a much larger series. But that doesn't really make sense from a statistical point of view, because you've already proven with a highly significant p-value that this is the association. I think a much better approach is trying to understand what does the immune score mean, how do we interpret it. So rather than going on with a 4,000 patient series, maybe we should think a bit more carefully about how we could better explore immune score as a tumour marker. So some key questions that we thought about. Is there any interaction with clinical variables? Any interaction with molecular variables? And an obvious one is microsatellite instability. So we know microsatellite instability is associated with inflammation and a good prognosis, so maybe immune score is a surrogate of MSI. These series all report an excess of deaths, but they don't tend to have data on whether patients died of cancer or of other causes, which is what we've got. And ultimately, should we be selecting these patients for treatment? So this is a collaborative project again that was conducted with support from Ventana, and Paul Waring led it from a pathology perspective. So what Ventana have got is a series of very good antibodies to different immune markers. They're all listed there. What I'm talking about today is CD3 and CD8 related markers, but we've also got data on CD20, FOXPRO3, PD1 and BRAF, which is important because of the association with microsatellite instability. So Ventana have image capture software that can define the sections of the tumour, and then after staining can actually score the samples in a very reproducible and robust way, unlike all of the previous immune scores, which were quite variable in terms of how they approached it. So we scored these similar to what Jerome Gallon and colleagues did, looking at the tumour centre and the invasive margin, scoring 0 or 1, and scoring for both of the antibodies. In our series, we had comprehensive clinical data, which they didn't have. we selected a particular group of patients, the stage 2 colon cancer, where there's a particular clinical need to define biomarkers, rather than looking at what was available, which is, I think, the approach that they took. And we also had the ability to look at cancer recurrence, cancer death, and non-cancer deaths. And also up front decided to look at mismatch repair status as a potential confounding factor. So a couple of things jump out from our initial look, and this is quite recent data, so a lot of it hasn't been looked at exhaustively. But one of the nice things about our scoring system is that half of the patients fell into the immune score high group, and about half of them fell into the immune score low group. So it divides up nicely into two groups. Shown here is that the patients with an immune high score tended to be younger. So younger patients have a better prognosis. Maybe immune score is partly a marker of younger and fitter patients. There's an imbalance between left and right colon cancers, which is also a known prognostic factor. And we also found, as we're expecting to see, that there's an imbalance between mismatch repair status. So overall, about 20% are deficient mismatch repair, but it's predominantly seen on the right side, about 35%, rather than the left side, where it's about 5 or 6%. We know that MSI high cancers have a better prognosis, maybe associated with immune score, so understanding that interaction is very important. So what we're showing here is that the immune score is very strongly predictive of outcome. So that's the classification of a score 0 through 4, showing that the score is a very strong predictor, and clearly it defines patients into different groups. So some of the novel data that we've seen as part of this series, we've seen that the prognostic significance of immune score is independent of the mismatch repair status. So whether you've got deficient mismatch repair high tumours, shown in the red and the yellow, or mismatch repair proficient tumours, this nicely divides up. So immune score is not a surrogate of deficient mismatch repair. It's independent of that and could be useful in both of these patient subsets. Another important finding shown down the bottom here was that immune score was very strongly associated with death without cancer recurrence. So on the left side, lower left, we're seeing the death rate according to mismatch repair status. So whether patients had deficient mismatch repair or not, overall survival was the same, whereas on the right side there's a clear and marked separation in the curves in patients according to their immune score. So basically what this is telling us is immune score is a marker of overall fitness, and some of the prognostic factor is due to cancer recurrence and death, but maybe there's a major component of death from other causes. So understanding why a biomarker predicts outcome is very important to clinical utility. So we've shown that immune score is associated with younger age and with right colon, both positive prognostic factors, and obviously a multivariate analysis will help us to better understand that. We've shown it's independent of deficient mismatch repair, which is an important step. And we've shown it also predicts an increased risk of non-cancer death. So moving on to our next potential biomarker. So we know as tumours develop, they acquire mutations, and the mutations that occur within tumours are tumour-specific. And if we find that mutation in the circulating blood, in the circulation, we know that that must be from a tumour, it's not from normal DNA. So this is work looking at circulating tumour DNA. So shown on the graphic here, tumours release circulating DNA into the bloodstream, can be by necrosis or apoptosis, and we can measure that circulating tumour DNA as a very specific marker of the presence of cancer. So looking at our clinical dilemma in terms of stage 2 cancers, is the patient going to recur or not? Can we predict that? Can we improve our way of approaching this and improving our targeting of our therapies? So just to walk you through how we could potentially use circulating tumour DNA in the context of minimal residual disease. So this is a patient, the CT scan shown on the left. The CT scan at the time of surgery was clear, no evidence of metastatic disease, no adjuvant therapy was given, and unfortunately a couple of years later there's quite widespread liver metastases. So what that means is at the time of surgery there is very small volume micrometastatic disease which wasn't seen, not detectable by CT scan. The hope with circulating tumour DNA is that we can detect many of those cases, even very small volume disease that can't be seen on CT scan, define those patients at high risk of recurrence, and then target those with adjuvant chemotherapy. So why would we do prospective-based clinical biomarker trials? This is not something that our colleagues have tended to do. I don't think there's any biomarker studies in colorectal cancer that have been successfully completed, so it's just not something that's part of the routine oncology thinking. But this is one we undertook with circulating tumour DNA. So this is based on some very preliminary data from Johns Hopkins, where they looked at 16 patients that had liver resections for metastatic colorectal cancer. And what they're able to show in this series is that the patients without detectable DNA, 100%, no recurrence. And if you had detectable DNA as a marker of micrometastatic disease, residual disease, pretty much all of those patients had developed recurrence. So that to us looks again like a very dramatic difference in two patient groups, something that could be a potentially useful clinical biomarker. We don't have any retrospective samples that we could use. We don't have blood samples from stage 2 patients. So we needed to do a prospective multi-centre study across about 20 hospitals around Australia, and ultimately enrolled 250 patients in the study between July 2011 and September 2014. And this is really our first analysis of that, a median follow-up of just over 2 years, at which point 33 recurrences have occurred. Patients in the series were treated by their clinicians as they would normally be treated, so about 20% or so received chemotherapy and the remaining didn't receive chemotherapy as per routine practice. So to walk you through this, what we did was to collect tumour tissue, blood and clinical data on these patients. The tumour tissue and the blood was sent over to Johns Hopkins for analysis. They did targeted sequencing of genes within the cancer to find a mutation and then looked for a matching mutant DNA in the bloodstream. And if we found matching mutant DNA, the patient was positive. And then we tried to look at correlation with outcome. So a couple of things to mention first up. The detection rate's around 10%, just under 10%. So about 10% of our stage 2 colon cancers we can detect circulating DNA after surgery. And there was no association between detecting DNA and the presence of other high risk or known prognostic factors. So it appears to be an independent prognostic factor. And this reproduces largely the results that were seen in that small series of 16 patients with liver metastases, showing where we detected DNA after surgery, and this is the patients that didn't receive adjuvant chemotherapy. Where you had detectable DNA, pretty much everyone has recurred. Where you don't have detectable DNA, it's just under 10% in terms of the recurrence. So very clear separation in those two curves. And just to make the point of comparing that with, for example, our Oncotype DX colon cancer recurrence score, which is being marketed in the US and sold at about $4,000 a test. And that does have a hazard ratio of 1.38 compared to a hazard ratio of almost 22. So this is obviously a clearly better tumour marker in terms of predicting outcome. What's more interesting, though, I think, is the ability to follow these patients after their surgery and see what happens to the circulating DNA and what that might tell us about whether chemotherapy is being helpful. So this is looking at the patients that had serial DNA. So not all of the patients entered onto the study had serial blood collected, but there were some. And these were the ones that had detectable DNA after their surgery that didn't have chemotherapy. And as shown at the bottom here, of these 6, all had persistently positive DNA up to the time of recurrence, with one exception where the level dropped to be non-detectable for a period of time, and then there was an elevation and leading up to recurrence. In contrast, if we look at the patients that did receive chemotherapy, this is 4 of those patients. What we've shown here is the chemotherapy period. So there's initial sample after surgery, which is positive. Patients have chemotherapy. All of these patients had a negative level 3 months later, and then some of them, the first 2, the level increased, kept on increasing, and at this time recurrence was detected clinically. And what we saw overall was the elevation in circulating tumour DNA occurred about 6 months prior to the clinical detection. I think of most interest to clinicians, these other 2 patients, where the level was positive, they received chemotherapy, the negative level became negative, and those patients haven't recurred. So it indicates that maybe by doing serial DNA on these patients, we can not only tell who's at high risk, but also tell us whether those patients are benefiting from their 6 months of chemotherapy. Otherwise, they just get 6 months of chemo, and we wouldn't really know whether that's being helpful or not. We've reproduced this data in other clinical series. This is preliminary data from a rectal cancer series. Again, the hazard ratio 24, and showing that after rectal cancer surgery, if DNA is detectable, those patients are destined for recurrence. Equally importantly, I think if you don't have DNA detectable, you've got a very low risk. So we're defining a group that clearly should be thought about in terms of adjuvant therapy, but also a very low risk population where adjuvant therapy can be left alone, patients reassured they've got a low risk of recurrence. So DNA, I think, is a prognostic biomarker, a very powerful prognostic biomarker with hazard ratios in excess of 20. But for the first time, we've got predictive biomarkers in medical oncology and early stage disease, where we can look at markers and define which patients to treat, and also look at the serial collections over time to see whether the treatment's being effective. So potentially what we could do would be look at our circulating tumour DNA population on the left there, it's 10% or so of patients, and just treat those with adjuvant chemotherapy, and hopefully we'd end up curing 2 people. So maybe we can treat 10 and cure 2, rather than treat 100 and cure 3, and obviously that odds ratio is much more encouraging. So just to change pace a little bit, talking about metastatic colorectal cancer. So this is disease that's unfortunately spread. So the patients developed a bowel cancer and it's spread to distant organs, typically to the liver for colorectal cancer. So our treatment options are increasing for metastatic disease, which is good, and we're seeing median survivals that are continuing to improve. But just to make the point again, that's a very expensive way to improve outcomes. These drugs may cost $8,000 or $10,000 a month and may improve median survivals by several months. And unfortunately, lots of debates also about, or ongoing uncertainty about which drugs to use for which patient. We haven't really done the clinical trials to compare different combinations and different sequences. And our biggest dilemma probably currently is this dilemma of whether to use, with our first-line chemotherapy, a biologic targeting EGFR or a biologic targeting VEGF, or whether we should do it the other way around. We know we can't give both at the same time. And there's a couple of clinical trials showing differences in terms of sequencing, and still a big question for the clinician. And it's going to get more complicated as well. So we've got regorafenib, that's another agent that's been shown to be helpful. Again, the impact is modest. So regorafenib improves median survival by 1.4 months, so about 6 weeks. And that's been enough to get it approved and used in the US, despite it also being quite a toxic drug, and charged about $7,000 or $8,000 per month. There's also many targeted therapies that are coming through as we're defining subsets of patients that benefit from targeted therapies, whether BRAF mutations, MSI high cancers and HER2 overexpression. There seems to be promising clinical data for all of those. So within the next few years, we're probably going to have 8 or 10 different drugs and almost numerous possibilities in terms of how they could be combined or sequenced. So we see our patient in the clinic, the newly diagnosed metastatic colorectal cancer. So what do we do with our chemotherapy? There's some where it may be appropriate to watch and wait and do nothing. We could look at single agent, double or triple therapy. They're all possibilities. And with the biologics, we could look at no biologics, adding an EGFR inhibitor or adding bevacizumab. So what to do for our patient sitting in front of us? So like I was mentioning before, there aren't really too many biomarkers that help us in metastatic colorectal cancer. If patients have a RAS mutation, we know they're not going to benefit from an EGFR inhibitor, but that's pretty much the only biomarker that we've got for our routine care patient. What's unfortunately happened is that people have tried to develop guidelines to tell us how to treat our patients with metastatic colorectal cancer. These are the NCCN guidelines from the US. That's a dominant guidelines worldwide, which most people look at very carefully. And it's quite obvious if you look at these, you've got a patient appropriate for therapy, and it doesn't really tell you what to do after that. So there's a long list of possible treatments, single agent, double combinations. There's one biomarker in here, which is KRAS. There's no other biomarkers. And it just says if you start with A, you have B. If you start with B, you have A. It's pretty much as precise as it gets in terms of clinical guidelines. So this is guidelines for metastatic colorectal cancer. And down the bottom, it's actually obscured. It's actually the first of 6 pages. So there's 6 pages of text with arrows and instructions, but it doesn't really help to treat the patient sitting in front of us. We also know that not all metastatic colorectal cancers are the same. Tumours are very heterogeneous, and different deposits may have different characteristics, and patients are also very heterogeneous, coming different sizes and shapes and ages, all of which can impact on our treatment and on the outcomes. So our approach is to choose our best option, and that's a bit of a guess sometimes. We treat for 2 months, so patients typically have 2 months of chemotherapy, and hopefully after that 2 months of chemotherapy, we repeat a CT scan, and we can see that the spots in the liver, these large liver metastases, have shrunk, which is our indication that treatment's being successful. Unfortunately, it doesn't always go that way, so sometimes we start with small deposits in the liver, and we end up with larger deposits. So the challenge really is trying to work out which treatment to use for these patients to achieve the former result and not the latter result. One of the problems with giving 2 months of chemotherapy, where you're not sure whether it's working or not, is that the patient's being exposed to ongoing cycles of treatment, ongoing expense, ongoing adverse events, and we're still not sure that it's working. So understanding early on whether the therapy is being effective would be a very helpful marker in terms of routine clinical practice. It's also important to highlight that many of our patients don't get beyond first-line therapy. This is a series of just under 5,000 patients from routine clinical care in the US. And in this series, 100% of patients all got first-line therapy. Only 50% made it through to second-line therapy. Only 25% made it through to third-line therapy. So we can't just say, let's start with our best option, then give our next best option, then our next best option, and just cycle through things, because many of our patients won't be alive or fit enough to have the treatment. So this debate about anti-EGFR therapy or anti-VEGF therapy first, which should we do, that could be informed by a biomarker. So one of the interesting things that we've been looking at in recent years, becoming very topical, is the difference between right and left colon cancer, reflecting probably the embryologic origins of midgut and hindgut. And one of the key differences between those is EREG expression, or epidermal growth factor receptor ligand expression, which is much higher on the left than on the right, and the potential marker of sensitivity to cetuximab, an epidermal growth factor receptor inhibitor. So there's some quite interesting clinical data coming out to support this. So this is a randomised clinical trial. Patients were randomised to receive FOLFIRI, so combination chemotherapy plus an EGFR inhibitor, or to receive FOLFIRI plus bevacizumab, an angiogenesis inhibitor. And in the group receiving cetuximab, those with a left colon cancer had a much better outcome than those receiving a right colon cancer, with a quite an impressive hazard ratio of 0.35. In those receiving bevacizumab as their first-line treatment, there was a slightly better outcome in the left-sided cancers, but it wasn't significant, and the hazard ratio is not near as impressive. So it suggested that maybe this ligand expression, this story of left versus right, could be used to guide our treatment decisions. The first thing we did was to look at our own series of patients. So we've got our database, we've got patients we know that have been treated with cetuximab, we've got outcome data, we know whether it's left or right. And what we're able to do in our own series is to validate that as a biomarker. So right colon cancers receiving cetuximab versus left colon cancers receiving cetuximab, quite a big difference with a hazard ratio of 0.53, supporting that left-sided colon cancers might benefit more from EGFR inhibitors. There's also data from another randomised controlled trial. So this is the CO17 study conducted by the AGITG in Australia in collaboration with Canada. And what we showed looking at this group of patients, comparing cetuximab to best supportive care, in the left colon cancer group, cetuximab-treated patients did much better than the control group. Again, a hazard ratio, very impressive hazard ratio of 0.28. In the right colon cancer, whether you got cetuximab or not, the outcome was pretty similar. So quite another striking example of a difference between right and left outcomes in EGFR inhibitor-treated patients. And in this series, they also looked by PCR at epiregulin expression and found that it was much higher on the right side than on the left side. So this prompted us to do some further research looking at EGFR ligand expression using antibodies to EREG and to AREG. So this is a collaboration with Paul Waring again and with Ventana. Importantly, Ventana have, and I think they're probably the only group that have antibodies to EREG and AREG available, and so they're able to provide that as part of this collaboration. And what we can see here is that there is some heterogeneity, which wouldn't have been picked up on a PCR-based assay. It's important to understand that. So patient 1 is positive for both the EREG and AREG, patient 2 positive for AREG, and patient 3 is negative for both of those. So there is a difference between the different patients. And what our preliminary data shows is that EREG expression is associated with PFS with a very powerful hazard ratio, and even better if you combine EREG and AREG together, the hazard ratio is about 0.1. So looking at EGFR ligand expression, we can predict which patients are going to benefit from cetuximab and which ones won't benefit from cetuximab. So how do we move that from a promising biomarker to something that we can use in the clinic on a routine basis? So certainly we're going to do further studies in existing cohorts. There's other clinical trial cohorts where this can be looked at. But ultimately what we should be doing is a prospective clinical trial looking at EGFR ligand expression and outcome. So just to take a step back, as part of our effort in collecting data for colorectal cancer, what we've been doing is adding additional groups from initially within Melbourne, then throughout Australia, and now internationally. So the idea is that we'd have a registry where everyone collects the same data on their patients with metastatic colorectal cancer. The same data is being collected. This is supported by Roche and began in July 2009. So we've got a defined data set, and all patients in the clinic are followed from diagnosis through to outcomes. And obviously, the important part of this was biomarker validation, but there's lots of other potential uses of a data source like this. So it's continued to expand. We've got data now on over 3,000 patients at sites throughout Australia. So that was a list a little time ago, about 27 sites that are collecting the same data on their metastatic colorectal cancer patients. There's another 5 or 10 that are hopefully going to join in the near future. And this includes a very mixed patient group. So it's in white, it's the public hospitals, in green, private hospitals, and in yellow, the regional centres. So we're starting to look at differences between public and private and regional centres, and we have produced some publications looking at those, showing some interesting differences. So all of this happens on the BioGrid supported model. So just to remind you, if you're not familiar, BioGrid is a federated data system. And what happens is each of these hospitals has a copy of the database that is installed on a local server, and each hospital, the clinicians own and control the data, enter it locally. When we want to combine data for research purposes, the BioGrid technology de-identifies the data, brings them into a common database, and then that can be queried. This means that each of the clinicians contributing feels confident they control and own their data, and it also means it's easier from an ethics point of view because all the data is de-identified prior to being combined and looked at. So as I mentioned, we've got some international collaborations now. We've started collecting data in Hong Kong, 2 major centres there, and ongoing discussions with several hospitals in Singapore. So hoping to get to a point where we maybe can collect about 2,000 patients per year with metastatic colorectal cancer, all collecting the same data in the same patient group. So registry-based randomised controlled trials is another novel concept that we've been looking at, and something that I started talking about 5 or 6 years ago. Wasn't very well received. It's becoming a little bit more well received now. So registry-based trials have been undertaken in cardiology for a number of years. So there's lots of large cardiology registries. The patients present with their heart attack or their other cardiac event, and they're randomised, and the data is captured in the registry. There's multiple output from that, high-impact publications. Unfortunately, cardiology is a lot more simple than medical oncology. We were following patients over a prolonged period of time. But my thought was with our TRACK registry, where we're collecting data on treatment and outcomes, if we could randomise patients and still collect the data, we would be effectively doing a randomised controlled trial. So part of the attraction of such a study is that you could have quite broad eligibility criteria, unlike the very carefully selected controlled industry-sponsored clinical trials, and hopefully be able to address important clinical and biomarker questions rather than, again, having to address the questions that our sponsors are keen to be pursued. So a couple of questions that we might be able to look at for a registry-based randomised controlled trial, which we're calling TRACK-SIDE. And a clinical question, does the primary tumour site impact on EGFR response? We've seen that looking retrospectively at established cohorts, clinical trials and routine care, but it would be very nice to demonstrate that prospectively. And also to understand the interaction between tumour site and EGFR ligand expression in terms of outcome. That's really what we need to do to move to a test that has clinical utility. How do we use the primary site information? How do we use EGFR ligand expression to improve treatment of our patients and, most importantly, improve outcomes? So this study is currently being designed, and we're planning to open it later this year at multiple centres across Australia and internationally. So these will be patients with metastatic colorectal cancer with KRAS wild-type tumours. We'll be stratifying according to right and left primaries, and then randomising to chemotherapy plus an EGFR inhibitor or chemotherapy plus bevacizumab. At the same time, we'll be collecting tumour tissue, looking at epiregulin expression. There's a number of other molecular analyses that we're looking at, including immune profiles, which appears to be prognostic in this group. And we're hoping to also get funding from an industry partner to collect serial plasma samples. And there's lots of potential markers, circulating tumour DNA and others, that we could look at in serial samples from this patient group. So again, this is something that's not really been thought about for oncology, thought to be too hard. And really the dogma is you can't do cancer clinical trials outside the conventional structures of the cooperative group or industry sponsored, but we're going ahead and we'll see how we go. So some of the attractions, I think I mentioned that we can include a lot of patients and not have the exclusion criteria that a lot of clinical trials do. But the major attraction is that it's inexpensive. The data's already being collected. We can randomise patients to receive treatments which are standard of care and otherwise available. And the estimate is we can do these studies for under $1,000 per patient, whereas most industry-sponsored first-line metastatic colorectal cancer, the budget's about $40,000 per patient. And this includes all of our clinical data and our biomarker data. So we're looking at the treatment and outcomes in routine care. So these are routine care patients, not selected patients. They're routine care doctors. So these are doctors that are treating lots of patients in the community. So this will be private sector, regional centres, metropolitan centres. Maybe doctors that don't follow protocols so carefully, a little bit loose in terms of how they follow up patients. But that's actually the right setting, I think, to be doing clinical trials. Unfortunately, one of the dilemmas we have, a very selected patient population, very carefully conducted clinical trial with expert research nurses, pharmacy, etc. You're producing an outcome in a very selected, very tightly controlled environment, and then trying to move that data into the routine clinical patient, trying to work out whether it's relevant, whether it moves across. So it makes sense to me to be actually doing the clinical trial in the population that's being treated in routine care with our average doctors, average nurses, average pharmacy, etc. In terms of clinical utility, one other potential biomarker, moving beyond which agents to use, so moving beyond which drugs to select, chemotherapy or biologics, is a question of, is our treatment working? So after 8 weeks of chemotherapy, this is what we don't want to see, where a patient starts with a little bit of disease in the liver, we give 8 weeks of therapy, and then we end up with this result. So again, circulating tumour DNA could be potentially a marker that could help us in this scenario. So this is work we did collecting circulating tumour DNA before and after the first cycle of chemotherapy. And what we did then was to correlate that with the outcome that was seen after 8 weeks of treatment as measured by the CT scan. What we're able to show is that initial changes in circulating tumour DNA after only one cycle predicted what the outcome was going to be at 8 weeks. So potentially we could be looking at a prospective study where we're looking at a response after only one cycle and hopefully getting away from treating patients with multiple cycles that aren't effective and are causing toxicity. And hopefully getting to a point where we're treating more patients with multiple lines of therapy rather than a situation currently where only half of our patients get beyond that first line of therapy, and if the first line of therapy doesn't work, they're really struggling. So just to summarise, I think the future of biomarkers in medical oncology, I think the prospective randomised biomarker studies as we've been doing them can be very helpful. We've now got a prospective study looking at ctDNA guided treatment in stage 2 colon cancer versus standard of care, looking at outcomes. There's obviously lots of potential in combining biomarkers. Our circulating tumour DNA cohort is different to our immune score cohort, so it'd be nice to do the immune score on the circulating tumour DNA patients. And fortunately, because we have conducted the study ourselves, we own and control the tissue. If this study had been conducted by industry, there's no way you could get a hold of the samples. There's lots of other markers that we're looking at currently, just about to publish on GIV. There's also MAXI1, both collaborations with Ventana, and an expression signature that we've also got an industry collaborator we will be sending tissue and data across. For metastatic colorectal cancer, I mentioned the trackside study looking at treating patients according to left and right colon cancer, understanding EGFR ligand expression. We're also looking at prospective studies, ultimately where circulating tumour DNA after one cycle can determine further treatment. And just to finish up, being led by Tony Burgess, and I think very exciting from an oncology perspective, is looking at organoid cultures. So these appear to reliably reproduce the architecture and the other characteristics of tumours, and we can grow these within about 3 weeks. So what we're thinking is we can collect the tumour tissue, establish an organoid, treat with a period of chemotherapy, work out which treatment's likely to be effective, and then to use that in the patient rather than the bit of a hit and miss that we're doing currently. And initial data, certainly from Hans Cleaver's, suggests that the responses in vitro culture predict the response in the patients. It's a very exciting development in medical oncology. So just to finish up, there's a large number of clinicians that have contributed. All of the circulating tumour DNA stuff has been done by Jeannie, who's worked very hard and very long to take this through to success. Ben Tran has been helping with our immune score. Ben's also has an interest in prostate cancer, so we're starting to look at collecting data and samples in prostate cancer. Belinda Lee, who's driving a pancreatic cancer program, starting to collect data and tumour in pancreatic cancer. Margaret, who's helping with our organoids and our prospective registry-based trials. JS leads the phase 1 trial program at the Royal Melbourne Hospital. Rachel is a medical oncologist at Box Hill, who's been a key collaborator and a very valuable source of tumour and data. And Xiaowen Locke just recently joined us, is driving an effort in breast cancer, HER2-positive metastatic breast cancer. And finally, Michael Christie, who's about to join us as our in-house pathologist, which is obviously critical, having high-quality pathology expertise to understanding these studies. I'll finish there. Thank you.
Peter, it's a very impressive case for increased emphasis on biomarkers, but I would have thought surely whole genome sequencing must be something that's going to be very illuminating in the long run, and there are enough patients that have been done so you can correlate it with specific treatment and outcome. What do you think?
No, I think there's a lot of potential. So one of the exciting things is, as I showed in the graph, the number of biomarkers is going up almost exponentially, and we're in a good position, I think, to understand not just one biomarker at a time, but potential interactions between multiple biomarkers. And once you start to do the statistics and you look at left versus right, or KRAS mutant or KRAS wild type, there's lots of subsets that need to be looked at. You do need thousands and thousands of patients. So that's the objective with the TRACK registry and the international collaborators, to ultimately have 10,000, 20,000 patients with tissue and data that we can start to do some of these correlations with, which nobody else will be able to do. So that's putting us in a very, very good position. Yeah.
Is there an estimate of how many residual tumour cells there have to be able to detect circulating tumour?
I'm not sure. I think the answer depends a little bit on where you set the bar in terms of calling it positive and a negative, which will vary according to a screening or a prognostic setting. I think the number is getting smaller and smaller, so we're getting better at finding smaller amounts. But there isn't a bar currently, and we don't quite understand how many residual cancer cells are required before we can detect it, but it's certainly a lot less than what is required to show up on a CT scan.
Is the DNA that you detect just a marker of metastasis?
We believe so. The ctDNA is shed from the tumour into the circulation. Obviously, very small volume disease, you can still detect it. I didn't mention it today, but we're doing also some work in screening. So in early stage cancer, 50 to 60% have detectable DNA. It's potentially a very useful screening test, but that'll be a very long story that'll play out over a period of time. But it's obviously very specific to tumours. If you find mutated DNA in the blood, and it's obviously a pathological situation.
Yes. So, very naive question in regards to the stage 2 colon cancer patients, where 20% relapse after surgery. could that just simply be to the fact that the way that the diagnosis of stage 2 is done is just still too crude, and that the ones that relapse are actually not really stage 2 but something else?
No, that's correct. They're stage 4 patients that we don't know they're stage 4 at the time of diagnosis, so they do have metastatic disease. So by definition have stage 4, but with our current technology, CEA as a biomarker, CT scan, PET scan, MRI, we can't detect that small volume disease. But you're right, they're all metastatic disease at diagnosis, but we just can't tell until they recur. And by the time they recur, they've got bulky metastatic disease that we usually can't cure. So the intent with trying to find them early is if we can target that group, the chemotherapy can hopefully eradicate residual disease and cure that group of patients.
Related question, I guess. How do you have any data concerning patients with stage 2 that have had their primary tumors resected at a later stage and they still have circulating tumor DNA, and could that be an indicator of what's going on?
We don't. So once we find bowel cancer, the surgeons and the patients are pretty keen to get it out. So we don't really have an opportunity to observe what happens over time. Don't really understand the natural history of cancer and how quickly it develops, because once we find a pathology, it gets removed. The only exception is the occasional patient not fit for operation or for whatever reason refuse to have surgery, and occasionally we get to watch the natural history, but mostly the tumours are out pretty quickly.
So what is the major barrier to widespread implementation of something as convincing as circulating tumor DNA and, guiding clinical therapeutic decisions?
I don't think there is any barriers. I don't think cost is. I think this will be a test that we can do for a few $100s, and should be widely available. Certainly with a blood test, you can take blood and send it off anywhere in the world, so you don't have to have a local expertise. We're hoping that pretty quickly this will get adopted into clinical care. But also, just as importantly, when people start to do future clinical trials, they'll stratify patients according to DNA. And if you add oxaliplatin or add another drug, that you're actually targeting a very select, enriched population. Don't have to do studies like that one, which was thousands and thousands of patients, trying to pick out a small difference in the hope that things will fall out. But I think a lot of potential in terms of adjuvant clinical trials.
Could you expand a bit on the left versus right-sided differences? What the biological basis of that?
I'm not sure that it's well understood. So, Rob Jorrison can probably answer that better than I can. So one of the debates is whether it's a continuum, whether there's a gradual change from right to left, a gradual evolution in terms of biomarkers. So we see a difference in MSI, BRAF mutations, EGFR ligand expression. There's other changes that occur around the bowel. We're not quite sure whether that's highest at the right and then slowly changes, or whether this dramatic cut-off 2/3 of the way across the transverse colon, which is where your midgut becomes your hindgut. So I don't understand. So embryologically, there's a possible explanation in different tissues of origin, but beyond that, we don't really understand the difference. It's something that's only become important probably in the last couple of years as we start to understand it in terms of EGFR receptor inhibitor response.
I was intrigued by your ability to predict non-cancer mortality with the immune score. Have you got any ideas what's going on there?
We're looking at it a little bit more carefully. So one of the first things to do is obviously make sure the patients we thought died of something else didn't die of cancer. So Belinda's very carefully going through the death certificates on these patients and looking for any evidence of cancer recurrence. Firstly, make sure our data is correct, but I think it's probably a marker of chronic disease, So if you've got a chronic disease, you probably can't mount a good immune response to cancer. That's probably the hypothesis at this point of time. So one of the thoughts that we would look at people who had a sudden death. So if you got hit by a train or had a suicide or something, death versus someone with a history of chronic disease, and see if we could understand. So presumably the poor immune response at diagnosis somehow is a signal of a poor general health, chronic disease, other risk factors for death. So we're expecting that's what we'll find, but we haven't really looked at that properly.
One last question from Tony. If the patient's wild type for RAS, how do you tell the difference between tumour and normal DNA?
Yeah, so we can look at RAS mutations or BRAF mutations or multiple other mutations. So as long as you can find a mutation in the cancer, you look for the same mutation in the blood.
All your patients, then
Yeah.
they've all had a mutation that you know about.
Yeah, so we've got a panel of 15 or 16 genes. In the future, hopefully what you would be able to do is have a panel that would cover 90% or plus of the common mutations, and then you wouldn't have to do the tumour typing to start with, but that's a necessary step at the moment. But I think in the future we'll be able to cover all of the known mutations with the panel and be able to just apply that directly on the blood without looking at the cancer.
Okay. Let's thank Peter for a great seminar.